Namaste and a very good evening to everyone present here. Myself Neetu, associated with the Multiple Sclerosis Society of India as a proud volunteer and a life member. On behalf of Multiple Sclerosis Society of India, I extend a warm welcome to all our distinguished speakers, respected doctors, healthcare professionals, our esteemed members from various chapters of MSSI across the country, our MS warriors, caregivers, volunteers, and all the other participants who have joined us today. We are truly honored to have each one of you with us in this important medical webinar. Your presence towards our shared commitment your presence reflects our shared commitment towards improving the quality of life for people living with MS. Today's webinar focuses on subject of intense importance for the MS community, that is vision and speech. So at this moment, I would like to invite Mr. Sandeep Chitnis, the National Secretary of the Multiple Sclerosis Society of India, to speak to us about the organization and its ongoing efforts. Sir, please.
Thank you very much, Neetu. Uh, I also welcome all of you. And most important thing is I will brief about Multiple Sclerosis Society of India, MSSI, in very short, because our society has started as NGO since 1985. And this is the only NGO which is looking after welfare of multiple sclerosis patients. Now, important thing is what we have been doing. We are doing all across, all around welfare of multiple sclerosis patients. But in this case, of course, all the financial things, financial support is coming. However, I would like to emphasize, as all of you are sort of connected with either multiple sclerosis society or in sort of either caregiver or MSPs. But I will like to emphasize what are the benefits of connecting with MSSI, even if you do not require any financial assistance. Most important thing is we are giving all updated information, and always there are our websites where you will get it, the latest information, and that will be very useful for you. Of course, in today's world, you are getting that information across on the net. However, in one place you can get that. That is one thing. Next one is we are doing many projects on counseling. So any person who is recently diagnosed with multiple sclerosis needs, apart from information, counseling also. And other 2 points which I would really emphasize, and these are all non-financial benefits of getting associated with MSSI. The another one is regarding disability certificate and UDID card. See, unless you have this, even if some people do not really like to get it, but if you get disability certificate and UDID card, lot of benefits will be flowing from RPWD Act 2016. That is Right of Person with Disabilities Act. This one is very important and we have seen lot of people getting benefit out of it, in a way that uh, sometimes even if you are working in some of the organization, and sometimes you are sort of transferred to some difficult location, transferred to some difficult job, then if you are having this, in fact, multiple sclerosis, our MSSI definitely helps for that also. We have helped earlier. And also the certificate is very important. In future, in case the 4% reservation quota is open, then all the educational society places, institutions, including IIM and other places also, you will be able to get that benefit. Currently, for MS people, we are not getting that. And that's why we are doing lot of advocacy work. This is advocacy work is pertaining to first of all, modifying the guidelines for uh, assessing disability, getting UDID, and now currently we have been working on getting insurance, proper insurance policy. And I don't want to go into details of that. However, getting proper insurance policy at reasonable premium and proper coverage of even DMTs is our endeavor, and we have been working on that. So for all these things, we need lot of numbers. So I appeal to you, if you are not uh, become member, and today you are present, please do become member of multiple MSSI. So by which collective efforts can be done to get maximum benefit out of the RPWD Act also, and also you will be getting special benefits of insurance coverage and all. We are even looking at group insurance coverage. So group insurance coverage, if it is done through MSSI, that is what we are trying, then it will be, otherwise if it is not available, it may be available through group insurance also. It is still under process, but again, numbers matter. Your number of people are very important for us. Now I will tell you the most important benefit we can get out of, means we are doing, which is non-financial. I am repeatedly mentioning non-financial because for financial support, people are coming to us. Non-financial is we are connected with neurologists across India, the top neurologists across India, and top hospitals also across India, including government hospitals. So people who want to get appointment, which is very difficult to get for most of these neurologists and all, will be facilitated. I always say not promised, but facilitated to get these appointments, and even to the doctors and neurologists, and also to various hospitals, including AIMS in Delhi. And means we do have the decent connection with all these treatments. With this, I stop because today you are not here for listening to me. Today we are here to listening to both the doctors and the topics which are very important, but not direct topic like neurology, but it is very important for quality of life of MS person, and also uh, looking at various advances. So I welcome Dr. Priyanka, uh, who will be talking about advances in vision care for MS, and Dr. Bhushan Jirgale, who will be talking on advances in speech care for MS. Over to you, Neetu. You can do the rest.
Thank you, sir, for the valuable address and sharing the important work that MSSI continues to undertake. We are grateful for your presence today here, sir. Moving towards the most awaiting sessions of the day, it is my privilege to invite our first speaker, Dr. Priyanka Kashilka Ketkar. Before that, I would like to read a few lines from her profile. Dr. Priyanka holds an MBBS, a DNB in ophthalmology, and has completed a fellowship in cataract and refractive surgery. She currently serves as the medical director at Lumos Eye and Health Clinic, where she leads with both clinical expertise and a strong patient centric approach. With hands on experience in over 1,200 ocular surgeries, Dr. Priyanka has established herself as a skilled and a meticulous surgeon. Her excellence has been recognized at the state level. She is the recipient of the prestigious Golden Hand Award for the Best Surgical Resident conferred by the Maharashtra Ophthalmic Society. She is also a recipient of the Merit Scholarship for Medical Education from Tata Trust. She is awarded for the academic merit and dedication to the field. In addition, Dr. Priyanka has also published various papers in reputed national and international journals covering a range of ophthalmic topics. A special mention about Dr. Priyanka. She was also one of the faculty at the annual Free Medical Camp 2025 organized by the MSSI Mumbai chapter. Dr. Priyanka, we warmly invite you to please begin your session. Over to you, Dr. Priyanka.
Thank you so much for the warm welcome, and thank you to all of you all to be present here today for this discussion. I will talk briefly about multiple sclerosis and the eyes. So, multiple sclerosis. Can you see my screen? Hello.
Yes,
Yeah, we
yes,
can
Sam,
see.
we can see.
Yeah. Okay. So, okay. So I will be talking about multiple sclerosis and how it involves the eyes, how to preserve and maintain vision as you are battling through multiple sclerosis. Um, before I, one second. Yeah. Is my screen visible?
Yeah, it's
Yes,
visible.
it's
Okay.
visible.
Yeah. So before I get into it, just a brief discussion about multiple sclerosis. It is an inflammatory, autoimmune, and degenerative disease of the central nervous system. In this, there are autoantibodies that are present to the myelin antigens that are present in the cerebrospinal fluid. Females are affected much larger extent than males, almost 2.5 times, and it affects young population, about 15 to 40 years of age. Because it affects the central nervous system, which is sort of the main electrical circuit of our body, it has immensely variable signs and symptoms. Coming to the basic fundamental unit of our central nervous system, this is a neuron. If we look deeper into this, this is the myelin sheath. Okay, this is the insulating material along the neuron, which helps in transmitting the impulse at a lightning speed all throughout our body. It insulates the part of the neuron so that electrical impulses can jump through these nodes of Ranvier, and conduction can happen very fast. Coming to pathophysiology of multiple sclerosis, although the cause of multiple sclerosis is unknown, there is a theory that suggests a complex interplay between genetic and environmental factors. As I mentioned, there is an oligodendrocyte which secretes myelin, which coats the axon, that is a part of the neuron. This helps in fast conduction of impulses throughout the body. What happens in multiple sclerosis is normally there is a blood brain barrier, because of which the inflammatory cells or the warriors of our body are inside the blood vessels in the brain. In multiple sclerosis, there is this blood brain barrier is altered. What happens because of this is inflammatory cells pass out of the blood vessels and into the central nervous system. These are the macrophages, T cells, and B cells. Once in the central nervous system, they are freely mobile, and they go to this myelin sheath and release factors. These factors then cause erosion or degeneration or demyelination of the insulating layer or the myelin in the neurons. So, as I mentioned before, it has varied presentations ranging from different organs of the body. So, it can cause weakness in an arm or leg. It can also cause numbness, tingling, and pain. It can cause balance problems and a lack of coordination. Fatigue is a common complaint. Cognitive impairment, getting confused or losing memory, or blurred vision are all symptoms of multiple sclerosis. Initially, these are a series of recurrent deficits and then followed by remissions or silent phases. Eventually, this leads to progressive and worsening disability. The disability is continuously progressive right from the onset of disease. So traditionally, multiple sclerosis is of four types, as we all know: relapsing remitting type, progressive relapsing type, secondary progressive, and primary progressive. So the relapsing remitting type is where there are acute attacks of symptoms. These attacks last for a period of 2 to 3 weeks or 4 weeks in some cases, and they are followed by intermittent periods of silence where the symptoms are not to that extent. However, as you can see, there is a slow disability that starts kicking in and progresses throughout the disease. The second type is progressive relapsing multiple sclerosis. In this also there are acute attacks of symptoms with a steady decline causing progressive disability. The secondary progressive multiple sclerosis type, initially there are attacks followed by then a steady decline in the neurological ability. And primary progressive, in which there is a steady decline right from the beginning and there are no specific attacks that happen in this. Relapsing remitting is the most common type of multiple sclerosis, and primary progressive is least common, accounting for 10% of the cases. As multiple sclerosis was studied further and looking at the natural history, it is found to be a continuum of neurological disability, where initially there is a subclinical stage in which there are no symptoms that the patient manifests. Eventually, there is a first demyelinating event. At this stage, the patient is monosymptomatic with just one attack of demyelination. Then the patient progresses to relapsing remitting type with clinically defined attacks of multiple sclerosis, which eventually lead to secondary progressive type. As you can see, the pink portion shows the neurological disability, level of disability that goes on steadily increasing throughout the course of the disease. What is interesting to note is that you can see the green arrows at the bottom. These are showing acute events of MRI activity. And although the first demyelinating event occurs at this point, you can see that there is MRI activity that occurs even before the first demyelinating event has occurred in the subclinical stage of the disease. I will discuss it further eventually in my talk, but this is an interesting finding that had come forward. And as you see, progressively the MRI activity goes on decreasing because the neurological disability goes on increasing. So the MRI findings are not as apparent later on. Coming to multiple sclerosis in ophthalmology, multiple sclerosis often presents with ocular symptoms secondary to inflammatory demyelination of the visual pathway. So majority of the patients experience at least one episode of ocular environment throughout their course of the course of their disease, and often ophthalmic symptoms are the first and only presenting symptom, in which case they are called clinically isolated syndrome. Typically it leads to temporary vision loss, but as we discussed before, there is progressive disability which can eventually lead to permanent some amount of permanent vision loss. Hence a knowledge of these is essential for early detection and better prognosis. So common symptoms, common visual symptoms that are associated with multiple sclerosis are eye pain or diminished visual acuity or blurring of vision, a central scotoma or blind spot, that is a spot as if you are seeing through scratched glasses, a blurred vision, jerky appearance of objects. Although the object is not moving, you can get a feeling that the object is moving, and double vision. So when multiple sclerosis is affecting the eye, why does it affect the eye when it is a disease of the central nervous system? So what happens is the optic nerve and the entire sort of cable network from the eye to the brain is an extension of the central nervous system, and it is also coated by the myelin sheath. So although the eye as such is normal, the conduction of impulses or visual inputs that you get from the eye, once they are being transmitted to the brain and transmitted back from the brain to the eye, this pathway is what gets affected, which is why it is affecting the eyes specifically and not any of the other organs. When I say it affects the eyes, it affects the pathway from the eye to the brain as well as from the brain to the eye. So the afferent pathway, or the pathway from the retina to the brain, when this gets affected, if the optic nerve is affected, that is the most of the part of the nerve that is closest to the eye, it causes optic neuritis. When the part of the nerve closer to the brain gets affected, it causes hemianopia or blind spots or black spots in the visual part of the visual field, depending on where it is affecting. When it affects the pathway that is from the brain to the eye muscles, or the nerve that supply the eye muscles. Depending on what nerve is affected, it can cause isolated motor nerve palsies or ocular misalignment due to imbalance in the nerve supply to the muscles between the two eyes. This causes diplopia or double vision. There can also be abnormalities of voluntary gaze like nystagmus, oscillopsia, the feeling of jerky movement of the object as if the world is moving. So coming to optic neuritis, it is the first clinical manifestation of multiple sclerosis in approximately 20% of cases. That is 1/5 of the cases of multiple sclerosis. 30% to 70% of these patients of multiple sclerosis develop optic neuritis during the course of their disease. Most often it involves only one eye at a time, and it can be acute, that is in a small duration of time. It can be recurrent, that is happening multiple times, or it can be chronic, that is over a long duration of time. Pain is the most commonly presenting symptoms. This pain happens when you're trying to move your eye, when you're trying to look right, left, up, down. There is also patients complain that the colors appear faded, and this desaturation of color is more in for red color than for any other color. There is a central spot that or blotch that appears in your central vision, and there can be flashes of light. There is also a phenomenon called the Uthoff's phenomena, in which if there is a transient rise in body temperature, which can be when you take a hot bath or if you're exercising, there is an acute increase in the amount of the symptoms that you get. After the body temperature goes down, again the symptoms come back to a baseline. On examination, what the ophthalmologist is trying to look for in your eye, in 35% of the cases, on the left side, what you can see is a normal optic disc. That is the base from where base of the optic nerve in your eye at the retina. So as you can see, the margins of this optic disc are very clearly seen in this, whereas the image on the right shows fuzzy blurred margins, which is because there is a lot of swelling or edema around the optic disc. How to detect it early? So the most efficient way to detect it will be an ophthalmological examination. The ophthalmologist will be checking your visual acuity. So if there is a sudden onset worsening over days or hours, it may be mild to profound, but it's usually mild to moderate vision loss that occurs. And after the attack subsides, there is an improvement in the vision. Color vision, as I said, there is red desaturation much more than other colors, but the colors generally appear faded. There is also a contrast sensitivity, contrast loss. So if you're trying to read gray letters on a white background, you are going to have difficulty in reading them. So high contrast letters like black over white will be much easier to read as compared to, say, gray over light, white backgrounds. So coming to the visual fields, what the black spots that you can see in the vision, if they have to be objectively seen by an ophthalmologist, a test called perimetry is performed. In this is a normal perimetry. The white area is what you can all see, and in optic neuritis, what happens is this turns black. So this is a way to objectively or sort of get a proof of how you are trying to see the world. So other tests that are done are OCT and VEP. OCT is a test that measures the thickness of the all the nerves that are present in your eye. Usually in acute phases, there is an increase in thickness, and over time there is a decrease in thickness. This shows that there is slow decline in the volume of the retinal nerve cells. VEP is a test that is done to measure how fast the impulse is conducting from the eye to the brain. So normally, as you can see, if the left eye is affected, the right eye shows that the impulse is getting conducted in, say, 111 milliseconds. That is when you get a peak, so the impulse is getting conducted. Whereas in the left eye, that is taking 134 seconds. So there is a slowing of the impulse, as well as if you can see, the height of the the wave is also reduced. So the impulse is slow and delayed. That is what is objectively measured in one of these tests. So before you diagnose an optic neuritis as a multiple sclerosis, there are a lot of other diagnoses that need to be excluded. So those were just some of them. Is it a relapse? So it's very important for a patient to understand if the symptoms they are experiencing are just a worsening of the symptoms, that the baseline symptoms that are present, or is it the onset of a relapse. So how do you understand that? Typically episodes last few weeks. So if there is a sudden loss in vision, it's probably related to maybe you've had a tough day and there is some fatigue that is present in the nerves, which is why there is transient blurring, which gets back to normal on rest. Earliest symptom is pain on eye movement. So if there is pain, there is a alarm that should ring, that okay, there is something wrong. When I'm moving my eye, I'm getting some pain. Also, the blurring of vision is usually mild to moderate. So if blurring is if there is a complete blackout that is coming back, or there is a blackout that is happening, then it is quite likely not a relapse and something else that is wrong with your eye. The easiest way to understand the amount of blurring is to cover one eye. So you cover one eye and then cover the other eye, and if you notice that there is fading of colors, blurring of vision, that is typically in one eye, along with pain in the eye movement, then it is quite likely that you are undergoing a relapse. At the same time, it's very important to understand, like for any other symptoms, there are good days and bad days. So on days that you are tired and you're fatigued, it's possible that some of your symptoms are going to get a little worse, but they will get better on resting. So not every patient who has an episode of optic neuritis goes on to develop multiple sclerosis. The 10-year risk was 38% and 12-year risk was 40%. So as the duration of multiple sclerosis increases, the risk, duration of the symptoms increase, the risk of getting clinically definite multiple sclerosis also increase. The strongest predictor, of course, is presence of brain lesions on MRI at the time of the episode of optic neuritis. Coming to other things that can happen with the eye, there can be uveitis, which is inflammation of the uvea, that is one of the layers of the eye. It is 10 times more common in patients with multiple sclerosis than in the general population. How this presents is there is eye redness, pain, difficulty in seeing light, and blurred vision along with floaters. This can very easily be treated as optic neuritis also. Along with that, there can be visual field defects, and there can be some complications that occur due to treatment with certain disease modifying therapy, which can be easily picked up by an ophthalmologist and treated. So now we finished the part from the retina to the brain. Now coming to problems that occur when the impulse is conducted from the brain to the retina. So eye movement issues in multiple sclerosis, these occur due to demyelination of nerves supplying the muscles of the eye involved in movement and balance. What you experience is there can be double vision, there can be feeling of the world bouncing. When you're trying to read something, there can be trouble focusing on something. There are also difficulties in balance. There can be dizziness or nausea because of this difficulty in balance and trouble focusing while reading. This can be because of something called internuclear ophthalmoplegia. This is when brainstem, which is a part of your central nervous system, when that is affected, it causes internuclear ophthalmoplegia. It is most commonly bilateral, that is both the eyes are affected. Here you can see a video of the patient trying to be examined. So the patient looks in all different directions. When he's trying to look up and out on the left side, the right eye is not moving. Whereas when he's looking down and on the right side, both the eyes are moving very well. This shows that the right eye is affected. See, when the patient looks to the left, the right eye is not moving. So when the patient typically looks to the left, the patient is going to complain of double vision because one eye is looking straight and one eye is looking on the other side. Whereas when the patient looks to the right, both the eyes are aligned. So the image or the what you're seeing is the same both eyes. Other things are dorsal midbrain syndrome. Then apart from that, nystagmus, which is to and fro repetitive movement of the eyes, also occurs due to brainstem involvement. This causes a difficulty in stabilization of images. uh, it can be horizontal, as seen in the picture, horizontal jerky nystagmus. It can be vertical, or it can be moving to and fro like a torsional nystagmus. This causes a feeling of oscillopsia, or that the world is moving. So, how multiple sclerosis is diagnosed? There are certain things that have changed over time in the diagnosis of multiple sclerosis, and I'll just briefly discuss about that. How traditionally multiple sclerosis was diagnosed was that symptoms would appear, then you would go for an MRI scan followed by a CSF analysis. Then the doctor would take all of these reports, exclude other causes of all of these symptoms. Once that was done, then multiple sclerosis would be confirmed. So the diagnosis was typically made by the McDowell's criteria in 2017, where there was, the key words here were dissemination in space and dissemination in time, or dissemination in space followed by CSF or cerebral spinal fluid positivity. So what does dissemination in space mean? Dissemination in space means that there are clear lesions followed by normal tissue in between, and dissemination in time means that there are two events with a silent period in between. So according to the 2024, that is the updated criteria for diagnosis of multiple sclerosis, dissemination in time was not one of the things that is now required. What happened was that they found that because of so the original criteria was made so that the multiple sclerosis is not overdiagnosed, and patients are not living with the burden of multiple sclerosis without the actual need for it. But what happened over time is, what they realized, that if because of this diagnostic criteria and because of the need for evidence of dissemination in time, which means that two separate events have to occur for the patient to actually be enrolled into a treatment and follow-up schedule, patients got treated much later than they should, and that is why the disease burden also got worse. So now the criteria has been modified, and because of that, dissemination in time is not really a necessary diagnostic criteria. Also other things that are modified, I'll just come to them. MRI is of course an important diagnostic modality in diagnosis of multiple sclerosis. In the brain, you can see typical Dawson fingers. In the spinal cord, there are cigar shaped lesions. And in the optic nerve, as you can see here, the lesions are seen very clearly. Lesions are bright white, plaques that can be seen, as opposed to a normal optic nerve. So, as I said, dissemination in space and dissemination in time were two important MRI criteria that were earlier required, which kind of delayed the diagnosis of multiple sclerosis. So now in the modification of McDonald's criteria, initially there were 4 locations at which the doctors looked at the plaques on MRI. Those were the periventricular, juxtacortical, infratemporal, and spinal. Now the optic nerve is also included as one of the criteria. Here you can see the plaque, on the right side, the optic nerve is much brighter than on the left side. So that indicates that the right optic nerve is affected. So other criteria that are called paraclinical signs are paramagnetic rim lesions and central vein sign. So other tests that are also done to confirm the diagnosis of multiple sclerosis and optic neuritis are OCT, that is optical coherence tomography. The serial imaging is useful for comparing episodes and monitoring disease progression over a period of time. Systemic investigations are done to find out comorbidities, as well as to see how well the patient is doing. A lumbar puncture is done and oligoclonal bands and kappa free light chain index. So in the 2024 criteria for McDonald's criteria for diagnosis, it was also found that kappa free light chain index is as good as oligoclonal bands in diagnosis of multiple sclerosis. Also, another entity, which is a radiologically isolated syndrome, was defined in the new criteria. In this, incidental findings on MRI lesions in the central nervous system, white matter, in a pattern typical of multiple sclerosis, but in the absence of clinical symptoms, are suggestive of inflammatory demyelination. Observational studies have shown that slightly more than half of these individuals with radiologically isolated syndrome have developed clinical symptoms within 10 years of follow-up. So coming back to the continuum that I discussed at the beginning, there is a subclinical period where there are MRI lesions that are present and the patient is still not symptomatic. So if the patient is investigated at that time, it leads to early diagnosis and beginning of early treatment, which will eventually lead to better prognosis. So what are the differences in the 2017 criteria versus the 2024 criteria? CSF oligoclonal bands were only supportive, but right now they can confirm without the need for a second attack. A radiologically isolated syndrome is a new entity. Optic nerve lesions are now included, and dissemination in time is not required. Dissemination in space is enough, along with CSF positivity and MRI findings. MRI findings were better defined, and diagnostic focus was earlier to, as I said, to avoid overdiagnosis. But now the diagnosis is the criteria is to enable early and evidence-based diagnosis. So treatment of optic neuritis, as most of you know, it is with a short course of high-dose IV steroids followed by oral steroids. When steroids are given, they essentially just reduce the duration of the symptoms. They do not affect the eventual disability that is caused. So they are only to speed recovery, not reduce the debility that is caused later. That is done by disease-modifying therapy. In clinically isolated syndromes, patients with evidence of silent lesions on MRI brain significantly benefited from treatment of interferon, and that was seen in one of the studies. So, coming to treatment of all of the ocular issues that we discussed, if there is optic neuritis, then the patient has to undergo steroid therapy and, of course, disease modifying therapy. If there is diplopia, that is double vision, as you can see in the hand here, usually the symptoms that happen in these relapses come back to a baseline normalcy. So if temporary treatment is required, then patching can be done, in which you cover the eye that is affected, so the other eye that is open can easily see a single image and you can continue working. If you are already wearing spectacles, then you can put a tape over the glass of the affected eye, and the other eye can still continue to see clearly with spectacles. Of course, after the attack has subsided and baseline level is achieved, if there is still some residual diplopia, then the ophthalmologist will give you prisms to make sure that the few images are fused and you can still see single image. Physical therapy also helps, and there is a small residual that is left over. Eye exercises, occupational therapy, and physical therapy helps in helping your eyes to fuse these images so that you can still see them as one. For treatment of nystagmus or the involuntary movement that occurs, temporary treatment again can be patching and taping of spectacles. The patient sometimes realizes that in a particular position, there is a null point of nystagmus. That is, in a particular position, if you tilt your head, the nystagmus kind of becomes minimal. So head positioning also helps in reducing this nystagmus. Physical therapy can be done to focus on gaze stabilization so that the image doesn't move as much as it is otherwise. Prisms also can be given to stabilize the image. If none of these works, medication can be given to reduce the amount of nystagmus, and surgery is done in very severe cases. Other strategies to preserve vision in multiple sclerosis, of course, this disease-modifying therapy will reduce the relapse rates and slow long-term progression. Rapid response to visual symptoms is very important. If there are some new changes in your vision that you are noticing, it's very important to go and get yourself checked. Even without these symptoms appearing, regular screening with annual eye exams help in monitoring the disease over a long period of time. There are certain triggers that have been identified, like heat, increased body temperature, infections. Of course, when your body is fighting an infection, all of these symptoms kind of exacerbate. Any kind of stress and smoking also are triggers for these events. uh, Comorbidities have to be managed. So if you have diabetes or hypertension, it is great if you can keep them under control. A generally healthy body can fight multiple sclerosis much better than a body that is, debilitated because of diabetes and hypertension. There are certain other lifestyle measures that can be taken. Hydration and regular physical activity. So physical activity can cause an increase in body temperature. So physical activity has to be done with breaks, regular breaks, so that the body temperature is not increasing, so that you're not getting fatigued, but you are also getting some regular exercise. Limit alcohol and smoking. You have to eat foods rich in omega-3 fatty acids and antioxidants. These are walnuts, almonds, flax seeds, fish, if you are a non-vegetarian. Adequate sleep. It's extremely essential that you sleep like a baby, so you wake up like a baby and you're all refreshed to, take on the next day. Stress reduction can be done with yoga and meditation. Eye related measures. So apart from the measures that you can take for the entire body, there are certain things that you can do that are specific to the eyes. Reduce eye strain. If you have a number in your eyes, a refractive error, get spectacles that are appropriate for your eyes. Follow the 20-20-20 rule. That is, every 20 minutes, if you're using the screen, every 20 minutes for 20 seconds, take a break and look 20 feet away. Basically, what it means is every half an hour roughly, take a break for half a minute and look outside the window, and that will relax your eyes and reduce eye strain. You can also change the lighting of your house to make it proper, so that you're not straining your eyes to look at things, because with multiple sclerosis, contrast gets affected. So in dimly lit rooms, it's much more difficult for you to see an object than in a brightly lit room. And apart from this, assistive devices, rehabilitation and physical therapy can also be done. Assistive devices like high contrast aids, which increase the contrast of the material, magnifiers, digital zoom devices. Screen readers can also be used. Text to speech tool, your Google, your Siri, your Alexa, all of these are good options to reduce the strain on your eyes. There can be orientation and mobility training and occupational therapy for residual blind spots or scotomas that are affecting your central vision. It is still possible to have good mobility. So along with this, injectables, infusions, and oral disease modifying therapies have been used to target multiple sclerosis. Some of the disease modifying agents are mentioned here. They reduce the frequency of the exacerbations and slow the rate of appearance of new white matter lesions. Yeah. So in summary, ocular findings may be initial manifestations of multiple sclerosis and may predict additional demyelinating events. Visual disability has a significant impact on the quality of life of the patients and their rehabilitation. Not every patient of optic neuritis develops multiple sclerosis. However, there is an increased risk of development and progression of the disease with every attack. Recognizing these syndromes and signs will help clinicians develop an effective therapeutic plan. Serial investigations help you to monitor the progression of the disease over a period of time. Eye care specialists play an important role in the multidisciplinary approach required to oversee care of affected individuals. Visual rehabilitation and assistive tools can restore independence even when deficits remain. Lifestyle modifications and comorbidities contribute meaningfully to vision preservation, and the goal is to empower individuals with multiple sclerosis and their care teams to protect visual function throughout the lifespan. Thank you so much.
I think we can take the questions pertaining to this particular subject and subsequently move on to the next one, because then there will be sort of continuity. So,
Sure.
Madam Prasanjit here from Guwahati.
Hello, nice to meet you.
Yeah. I have got blood vision right from the year 2001.
Okay.
Actual blood vision due to MS. Now, is there any technology nowadays to, repair the damaged nerve?
I'm sorry, you're not clearly audible. Is there a technology too?
Is there any technology or medicine to, repair the damaged optic nerve?
Research is on to for neuro regeneration and neurological repair, but right now all we can really do is are you on disease modifying therapy that will prevent further
Not as such, because my progression has stopped as confirmed by the AIMS doctor.
Sorry, progression has?
There is no progression as far as the AIMS Guwahati doctors.
Okay, that's great. So, like I mentioned, there are ways to do visual rehabilitation. Um, Also, regular exercise will help you retain your ocular, whatever vision is left. And there are ways to work around how much vision you have lost. So, you can do physical therapy, you can do occupational therapy. There are also these gadgets for magnifying. A magnifying glass or screen recorders that can help you, but regeneration is not yet in mainstream treatment.
The doctors have told me that my optic nerve has turned pale.
Yes, so that does happen because of the demyelination and reduced blood supply. The optic nerve head that I had shown in one of the images, that's usually pink. So that becomes pale, which means that the potential of the optic nerve has reduced.
Okay, madam. Thank you so much.
Thank you.
Doctor, I think a couple of questions.
Excuse me. Please be brief and don't ask individual questions. The general thing needs to be asked. This is not a consultation session at the moment. So please, I request that you stick to general important points instead of specific individual issues. Thank you.
I can see that some questions have been put on the chat. Shall I address them?
Yes, please.
Doctor, I have one small request.
Yes, sir.
I was once told subconjunctive on my eye. It was in red color.
Sorry, I can't hear you.
Subconjunctive hemorrhage. That's what they told me.
Okay.
Now my eye was in red color.
Okay.
Not gone physically because I am bedridden.
Okay.
The video, they have told me that.
Right. So that is not related to multiple sclerosis. That can be because of fluctuations in blood pressure. It can be because of accidental rubbing or sometimes even because of sneezing, etc. But it's not directly related to multiple sclerosis.
Okay, madam. Thank you so much.
Yeah. There is a question about injections like rituximab or other DMTs affecting the eyes. Similar to other disease-modifying therapies, the occurrence of a relapse will be delayed or prevented if you are on disease-modifying therapy. And that is, are you talking about the positive effect or a negative effect? Because there are some disease modifying therapies that can cause side effects in the eyes, so I'm not aware if you're addressing that.
I think they have asked if dry eyes can be caused by these medications.
Yeah, so dryness of the eyes, unless there is a topical, unless you're putting a drop inside the eye and the surface is not affected, I don't think these medications can cause dry eyes. There are a lot of factors that do cause dry eyes, so blinking is not as prompt as it should be, and other things, that those things can cause dry eyes. So there are times when the eye hurts from within, not while looking left or right. Is it linked to multiple sclerosis? There can be multiple reasons for why the eye hurts from within. Most common is dry eyes. Uh, unless an examination is done, it's very difficult for me to tell you that on the message, but it may not be related to multiple sclerosis.
I think Maheshwari has raised the hand. Maheshwari Nursing.
I can't, how do I check that?
Yeah, Mr. Javed, please unmute her. Maheshwari. The person who has raised the hand.
Yeah, Mr. Maheshwari, you may unmute yourself and ask a question.
Mr. Vishal, if there are some things that require more explanation, I am more than happy to address your concern. So you can ask which part that it is that requires more explanation, and I'll definitely dive deeper into it.
Meanwhile, ma'am, I think there are two specific questions. One is by Mr. Dinesh.
Yeah. So is recurrent episcleritis related to multiple sclerosis, and what can we do to manage it? So recurrent episcleritis is a very superficial level of inflammation. It can definitely, the incidence of that will be more in a multiple sclerosis patient. But there can be other reasons also for it, like underlying infection in the body, inflammatory process in the body. How to manage it depends, of course, on how frequently it is occurring and if there are any other causes for it. Management is usually with eye drops of steroids or immunosuppressive agents that kind of reduce the symptoms. But the underlying inflammation, if it is not multiple sclerosis, that can be addressed, and that the even if the disease activity in the body is less, then episcleritis incidence will also reduce. So do persons living with multiple sclerosis get cataract earlier? So if the patient is receiving multiple doses or long duration of steroids during the course of their treatment, then yes, steroids do cause cataracts earlier than otherwise. Um, Disease modifying therapy, not most of them are not associated with getting cataract earlier, but yes, if you are getting optic neuritis and getting treated with steroids, then the incidence will be higher in earlier in multiple sclerosis patients. You're welcome. I think I've addressed all the questions in the chat. I can't get the question from the person who has raised their hand. If there are any other questions that need to be addressed, I'm available.
So I think no more questions are there. Or something in chat.
Yeah. So plasmapheresis, if episcleritis is the only symptom that is present, plasmapheresis would be an overkill of the situation. What can be easily managed with drops needn't require plasmapheresis. If the disease activity in general in the body is high, causing other symptoms as well, then definitely plasmapheresis will also reduce the recurrence of episcleritis. But by itself, if episcleritis is the only symptom, plasmapheresis would be an overkill.
So thank you very much Dr. Priyanka. I think there are no further questions at the moment. And in case something is there, the questions can be sent to our head office by email, and we will send it to Dr. Priyanka for whatever possible clarification is there. Neetu, you can take, Neetu ne, right now, Anushri, you can take over from here.
Sure, sir. Thank you so much, Dr. Priyanka, for that presentation. Indeed, I think vision is a popular and general concern for a lot of MSPs. Like you said, majority of the patients have at least one episode relating to the eye. So that was really relevant and informative for us. And with that, I would like to introduce the next speaker for today's session, which is Dr. Bhushan Jirgale. He is an alumni of BVDU School of Audiology and Speech Language Pathology, Pune 2012 batch, followed by Nair Hospital, Mumbai 2015 batch. He has also completed his fellowship in voice and swallowing pathology under Dr. Jayapura Kumar Menon, Trivandrum. And he has a wide range of experience as a consultant, speech and swallowing pathology at Hinduja Hospital for 8 years now, at Raheja Hospital since the last 4 years, and Nanavati Hospital for 2 years. Besides, he has completed a couple of various certifications. He has presented various papers at national conferences, and he is the co-founder of Bolo Dysphagia. And he has also been invited as a speaker at various CME and CRE programs on swallow rehabilitation. In addition to speech and swallowing, he is also a traditional Reiki master teacher and an integrated hypnotherapist. So, with that interesting profile, I would request Dr. Bhushan to take over for his presentation.
Thank you for the invitation and thank you for the nice introduction. So, can I start?
Yes, please.
Yeah, I'll share my screen. Can you see the screen? It's on the full screen mode.
Yeah.
Okay.
Yes.
So today we are going to talk about the speech and swallow solutions in multiple sclerosis. Definitely, many people, they do have a difficulty in their speech, cognition, and swallowing when they get an attack of multiple sclerosis. So speech language pathologist or a speech therapist, we are the allied health professional where the individual comes to us after all the diagnosis by the neurologist, by the MD physician, and when they realize the individual has a difficulty in speech and swallow, they refer to us and we work on their speech and swallow function. So we are going to have a quick overview about what are the characteristics, what we observe. That every individual may not have each and every difficulty. Every individual may not have a cognitive issues. Every individual may not have a swallowing issues. Every individual may not have a severe speech difficulty issues. So that's why it is very important to see what are the characteristics at the moment, what and how the speech has been affected, and how we can work on it. So we predominantly work on the three things, that is a speech, swallow function, and the cognition part. And we give the exercises. Most of you might have received some kind of a speech therapy or an intervention, maybe once, maybe twice, or maybe regular intervals. And all those exercises, interventions do help. So we are going to talk about the characteristics, assessment characteristics, and the intervention, which are moreover new in these days, and how all this combination of the exercises also work best with the patients. So the way whenever the patient comes to us, so it can be at different time, maybe at the when the occurrence of multiple sclerosis has happened, at that time the patient may come to us, or maybe after a few weeks when they have a consistent speech and swallow difficulty, or it's getting worse in that time, the individual can come to us or has been sent to us for the speech and swallow assessment. So basically the timing matters. When the patient has been assessed, it matters a lot. At the time of the incidence, or after a few weeks, or maybe over a day, in the morning time, in the evening time, or in the fatigue time, if we evaluate the patient, it's going to have some kind of a different findings across the day, across the duration of the disease. Environmental modification, we always take care about how to evaluate the patient. We see that There should be a good and adequate environment to evaluate the patient, because the individuals with multiple sclerosis can have different disabilities like a locomotor disabilities, vision disabilities, also difficulty in cognition. So considering all these things, we have to plan our session of assessment accordingly. Definitely multidisciplinary team is very much important in that, which help us to, or which guides also at times to plan our sessions for the same. So we do a two types of assessment, which is a subjective assessment and the objective assessment. In subjective assessment, it's like an interview kind of assessment where we ask the patient, we evaluate the patient clinically, we see how is their speech, how is their language, how is their swallowing, and we based on that, we plan the therapeutic intervention for that patient. The objective assessment is also these days is very fascinating, and it gives a lot of information about the speech, swallow, and the language functions, where we use different kind of instruments, or at times different kind of tests also be used, and based on that test we decide the severity, and we give the feedback to the patient about their speech, swallow, and language functions. So the speech assessment can be where we check how is the volume of the patient, how is the articulation of the patient, how the individual is speaking, how the pronunciation is happening, how the intelligibility of the speech when the individual is talking with someone, how effectively the individual can project their idea with someone else, that we check. We check about the language and cognition. Is there any cognitive issue at the moment? Is there any difficulty in communicating? Is there any difficulty in forming a sentence? Having a logical mind? Is there any lack of logical mind? Using that logical mind in the language function. And definitely we check about the swallowing, which is we do the four-finger test, where we actually give the individuals to eat in front of us, and we see how the individual is swallowing. So basically four-finger test, where we keep the four fingers on our throat and we check how effectively and how quicker the swallow is happening with the individuals. So based on these things, we do evaluate the patients about the speech, language, cognition, and the swallowing. And based on that, we diagnose patient that the patient has a dysarthria. Which type of dysarthria? It's a spastic dysarthria, ataxic dysarthria. Is there any cognitive issues, like a mild cognitive issues, severe cognitive issues? And if there is a dysphagia, then it's a mild dysphagia, moderate dysphagia, severe dysphagia, or patient is not able to eat at all. Based on that, we diagnose all these things. Moving forward. Coming to the objective assessment. So objective assessment will be done on different sections. Predominantly for the speech and the swallow, we do the objective assessment. The stroboscopy or the nasolaryngoscopy can be done, where on the screen you can see the scope will be put on the inside the through the nose inside your throat, and the vocal cord movements will be observed. So most of the time, many individuals with multiple sclerosis, they complain about having a aphonia, not able to phone it at all. When the incident comes, they are not able to phone it at all. So we check about what is the vocal cord position. Is there any kind of a difficulty? How is the pulling of the saliva? All these things we check. There are many voice softwares which are available at the speech clinics, Dr. Speech or MDVP Speech, which gives the information about the articulatory and the voice measurements, like jitter, shimmer, intensity, pitch range, the distortion in the voice. All those things can be achieved. The FEAST test, which is a fiber optic endoscopic evaluation of swallowing, which is a most right image you can see. The scope has been put from the nose and the food has been given orally. This test tells about is there any kind of aspiration and the delay in the swallow is happening or not. You can see it's a three-dimensional testing, where we can see the swallow function from the above, what's happening inside. And there is one more testing, which is a modified barium swallow or a video fluoroscopy, which is a two-dimensional test, which can be done at the hospital, and the swallow function can be evaluated. All these tests will tell you about how much is the safer for the individual to swallow the food orally. The voice software can be used at the different intervals whenever there is a speech difficulty. If you are taking a speech therapy and the language therapy, these softwares, the basic measurements, like a first evaluation, then the mid therapy evaluation, and the post therapy evaluations will tell you about how the individual is progressing along with this. The subjective assessment, where we use a different kind of a test and all, those also will tell about how the patient is improving or not, how much is the severity. The objective assessment will quantify. It will give you the numbers. It will give you the proof, the visual proof about how the intervention is happening, is it helping or not, or how we can move ahead with respect to our program. We'll show you one example of this modified barium swallow. So the black color, you can see the water or the food which is going. You can see how the patient is, the liquid has been put inside the mouth and the individual is swallowing very well. And after few intervals, you can see over here in the air pipe, the material is entering inside and there is a cuff. You can see the Ryle's tube going from the nose in the individuals. Over here, you can see the patient has aspirated and there is a severe cough on that. Now you will be able to see. So this is the modified barium swallow or a video fluoroscopy. The second test is fibroendoscopic, where the camera has been put from the nose. You can see this is the air pipe in between and this is a food pipe on the back side. This is a back side of the tongue. The tube is going into the food pipe. You can see a slight penetration of the food is happening between the air from here, from the arytenoids to the into the air pipe. So most of the time, many patients or individuals with the multiple sclerosis or other diseases also, they come with the complaint of they don't have a major difficulty on the swallowing, but after the swallow, they tend to have a cough. So in these cases, such kind of a test or objective assessment helps the individual to helps the patient also and the therapist also to understand what is exactly happening inside the throat. Moving on to the understanding the challenges in speech and swallowing. So there will be a definitely 65% population might be developing a dysarthria due to the disease course. There will be a slurring of the speech, slow speech, imprecise articulation, and reduced breath support. So breath support plays an important role for the speech production. As you all might have, all of you might know that if there is a poor breath support or a poor respiratory support for the speech, the volume of the speech is going to be less or not able to phonate. So most of the time, as the incidence happens of the multiple sclerosis, the breath support of the patient immediately goes down, and the most of the people they becomes aphonic. So they will try to speak, but the words or the sound or the strength of the voice will not be there. There will be a cognitive and communication difficulties. Word finding difficulties are most common in these individuals. They might be having a information processing delays. So if you ask the question, they may take a little bit time to process it and answer those things. And executive function deficits, like if you ask few common things also, it would be difficult to answer them. Dysphagia is also very common. It can be a delayed swallow reflex, reduced pharyngeal peristalsis, and fatigue during the meals. Also, what I have observed in the individuals with multiple sclerosis, the pharyngeal phase is not significantly affected than the oral phase. So propulsion of the food from the mouth to the pharynx, it takes a long time, and that also leads to fatigue and the dysphagia occurs. So basically, the swallow function might be near normal, but more affected function would be the oral phase and oral preparatory phase, where the chewing is involved, where the gulping of the bolus is involved, where pushing the bolus from the lips to the tongue to the pharynx, it is involved. So that thing might be affected severely. With respect to speech, we can see impaired articulation. Prosodic abnormalities is a very common thing. So nowadays, many people, they are working, many people are there. The communication is an important part. So though they are working or they are in their regular discourse, most of the individuals, they find their speech is a monotonous, where they are not able to have a multiple intonation patterns. They are not able to put the stress on the appropriate word. They are not able to take a pauses and affecting natural rhythm. When the natural rhythm is affected, they are not able to convey whatever they are saying. As I mentioned, there is a spastic and ataxic dysarthria. I will give you an example with the spastic dysarthria, where the whole tongue function will be slurred and the distortions will be, it will be like, hello, my name is So this way the speech can be there. Also in the ataxic type, where you can see the rate of speech might be very high, or it will be like a scanning kind of a speech where the abrupt projection of the sounds will be there. My name is Bhushan. This kind of a speech can also be there. We talked about the dysphonia, where there is no voice, or there will be a severe harshness of the voice will be present. Also, when we see on this dysphonia thing on the stroboscopy or the flexible laryngoscopy, where are the two vocal folds, they are not able to come together completely. So because of the muscle weakness, because of the poor breath support, they are not able to come together and give the adequate vibrations of the vocal cords. Respiratory support, there will be a weakened breath, there will be a poor breath support, so which can lead to a short phrases. The most of the individuals, they will speak in a single word or a two word. It's not because of there is a fatigue. Definitely the fatigue can plays an important role, but it can be predominantly because of the respiratory poor respiratory support. The language characteristics might be the word finding difficulty, the impaired discourse. If you're talking with the individual, they are not able to continue the same topic. Also, there will be a difficulty in narrative difficulties will be there. What has happened, what they are doing. They are not able to explain what exactly they want to say. In severe cases, this is severely affected where the individual tries to speak in a single or a two-word phrases also. The fluency will be affected where we can see the rate of speech. So if I speak with you like this, you will be bored. So in individuals, this can be present along with the dysarthria. So there is a slurred speech is also there, and along with that slurred speech, there is a slow rate of speech can be present. The individual can take up pauses at different at the wrong places where the meaning of the sentence or the meaning of the sentence will not be conveyed, and there can be a confusion, and overall it can lead to the confusion in the conversation. The pragmatic deficits can be present. Recently, I have not seen any significant individuals having a pragmatic difficulties, but there will be they will forgot to take the turn taking skills or so. If the individual has a very short breath and he wants to communicate, he wants to update, he wants to tell whatever he wants to say. So that time there is a poor listening capacity might be there, and the individual will speak in between when the other person is speaking. So this can be present. I would consider it is a more behavior because there is always a hurry to speak, and there is a pre-existing dysarthria or kind of a thing. That's why the intelligibility of speech is poor. So that's why the individual goes on or speaks in between when the whole conversation is going on. The cognitive characteristics can be there is a slow processing period. There will be a difficulty in executing day-to-day activities. There can be a short attention span where they will attend any activity or any conversations for a very short period of time. There can be a little memories issues can be there, and executive functions can be affected. So if you have to do one activity, how you will do it or how you will go ahead about it, that can be affected, which can lead to a difficulty in day-to-day life. So dysphagia can be, as I mentioned, the 80% of the individuals may have a oral phase difficulties where where the food traveling from the lips to the backside of the tongue would be a very difficult task. There might be a problem in chewing, bolus formation. It can leak from the front side, also from the lips, or at times if there is a liquid product, if you put it before initiating a swallow, before gulping, it flows back and there will be a difficulty in the swallowing. As you know, all the muscles are relaxed, all muscles are tired, or there is a weakness of the muscles. Along with that, the swallow muscles will be also have some impact of muscle multiple sclerosis, which will lead to a delayed swallow reflex. There will be a laryngeal elevation will be severely affected. The food which is going from the esophagus or from the pharynx will go in a slow motion, and it can lead to an overflow of the bolus into the air pipe or larynx, and it can lead to a aspiration. So aspiration risk always will be there because there will be an incoordination of the muscles, the oral phase and the pharyngeal phase, which can lead to aspiration, which we can see in the image, it is entering into the airway and leading to a cough. Moving on to the intervention, we are going to run through the few new techniques. All your speech therapist, whoever has taken a speech therapy, they might be aware about. There are some exercises like tongue exercises, pataka badaga, and all those things. And there might be some swallow exercises also, and the word retrieval issues also. So we are going to take an overview. I'm trying to cover what is new in this area, which we are using at the moment, we are doing at the moment. The rest of this speech and swallow program is going to be the same, but the new things can be implemented, and it will lead to a better progress in the speech and swallow characteristics. So if we talk about the evidence-based speech intervention techniques, so there is a respiratory support training. If we work on the respiratory muscles, so it is said that it will give a better strength to the voice, Also, it will help to have a better coordinated movements. So LSVT loud protocol, it's a Lee Silverman's voice technique program, which is a certified and copyrighted program, where the technique tells about you have to speak so much loudly as it the another person is standing on the other terrace of the building, and you have to speak to him in such a loud voice, so he should be able to hear. So this is the technique which has a step-by-step training program with respect to the timing, single word, 2-word, 3-word, 4-word phrases, how to use it, and it has a biofeedback technique in the copyrighted program which can be used and which can be implicated to improve the vocal strength and the voice. The expiratory muscle strengthening training, it's a device which is newly invented, which trains your all respiratory muscles, and which will help you to have a better phonation. We are going to see this technique, both the techniques in detail. So the coordinated breathing techniques, there are different breathing techniques of inhalation and exhalation, abdominal breathing, and our traditional yogic few breathing techniques are there that can be also the part of the breathing techniques. The articulation precision techniques, which are the rate of speech control strategies, where rate of speech control strategies, there are the counting the fingers as per the single word that can be used. The exaggerated articulation or open mouth resonance, where one has to open their mouth, use the tongue completely, and they have to practice it on the reading, single sentences, one-to-one conversation, and maybe they can be used for the regular discourse. The biofeedback, definitely the video recording or the audio recording of the speech and training your ears to have a better speech can be one of the techniques. Prosodic training, the stress pattern practice, how we speak to another person, like a exclamatory mark, questioning, asking for the things, angry voice. The same thing, the prosodic training can be given, the intonation training can be given, and the phrasing technique also can be given. So all these three techniques will be done in the combination, not in a single way. All these techniques predominantly, as a speech therapist, we train the individual on the reading part first, and after the individual is able to do it comparatively well on the reading, we move on to the single word sentences or a single words or a single sentences in the conversation. The external aids can be used with respect to the speech impairment, where the individual has a very poor voice. We can use the microphone to have a better output of the voice. Let's see the technique in the detail. It's a Lee Silverman's voice technique. It focuses on the voice, high effort, intensive treatment, calibration, and quantification. So it will help you to have a better voice. It will teach you how to put the high efforts to have a better output of your voice. Intensive treatment, definitely in the program, it has been given how many times a day you have to practice, the way, how frequently you have to practice, on which phrases you have to practice, it will give you. The calibration, it will tells you about your the volume, and the quantification, how much you can use in a day, it talks about that as well. So it is said that it increases the subglottal air pressure, it increases the lung volume excursion, and improves the swallowing also. So they have said that if you do any kind of activity voluntarily, then it trains all the speech and swallow muscles to have a better involuntary functions as well. So if you are training all your muscles voluntary, it is said that it improves your involuntary functions also. It starts with the saliva swallow in the night. There will be a less coughing, and also there will be a better swallowing while you eating the food. Moving on to the respiratory muscle strengthening training, there are two types: EMST, which is the expiratory muscle, and IMST, which is the inspiratory muscles. These are the respective diagrams of this. These instruments were not available in India few years back. Now these days it's available. So EMST, which is very much important with respect to the voice, swallowing, and the speech, because it will train your expiratory muscles to have a better breath support and a better strength of your voice. So this instrument, you have to hold it in the mouth this way. Only the one thing, you have to hold your cheeks like this, and then you have to blow out from this device. In this video, the individual is not holding the cheeks. So this way you have to blow, and it will give a air sound. If you see the instrument over here, you can see the red, yellow, and the green. These are the measurements. So it's a EMST 75 light, which has a 75 H2O pressure. There is a spring inside this instrument. So at 0, if you try to blow out the instrument, it will be very easy for you. But as you move the instrument, as you move the spring inside, the efforts which you are going to take is going to be a lot more. So as you put the more pressure, all the thoracic and the abdominal muscles of respiration will be trained, and your cough efficiency will be improved. The vocal strength will be improved. So it not only increases the cough, but also improvements in the velopharyngeal seal. So it improves the laryngeal elevation, and it improves results into the pharyngeal shortening, which is helpful for the swallow function. So moving on to the IMST, which is an inspiratory muscle strengthening training, it reduces the apnea. Most of the people who has a difficulty in breathing, the apnea can be reduced. It helps into the opening of the vocal cords, which will have a better respiration also, and which will be help in the better cough strength also. It helpful in the early stages of amyotrophic lateral sclerosis, multiple sclerosis, and spinal cord injuries, where the difficulty in the breathing or apnea is predominant. Moving on to the language and cognitive communication strategies, word finding difficulties are very common. The semantic feature analysis can be used. What is semantic feature analysis? If you want to talk about mango, if you are asking what fruit is this, if the individual is not able to identify the fruit, you can tell, oh, this comes in the summertime, which is yellow in color, which is very, very sweet. It comes from the hapus mango is very, very famous. So which is that fruit? The
Recording
mango.
in progress.
So it's like you are giving a more information about the word, the word, and the individual has to guess the word. So it's kind of a queuing technique which can be used. Word retrieval queuing hierarchies is also the same. If individual wants to have not able to identify the mango, then what you can do, okay, where we have visited over there to their home, what they have given us to eat, they cut it in the pieces, it was a yellow in color. So it tells more about the situational thing which individual has experienced. The categorical fluency training is like tell me 5 names of my fruits, tell me 5 names of railway stations of Mumbai, tell me 5 names of countries. So it stimulates the all category training, and it will be able to have a better retrieval of those categories. Discourse management, the cohesion training can be given, where having specific topic and talking about them will be trained. Topic maintenance practice will be there. So the speech therapist will take you back to the topic with the cueing, with some cues, with some gestures, and you will be directed to the topics. Organizational framework. So if you decide this is office, it's kind of a role playing which will help to have a better management. So imagine this is your office and you are going to give a kind of a presentation today. So let's have a presentation and you present in front of this. So such activities can be done in the therapeutic sessions. The alternative augmentative communication can be used. The individuals who has a severe dysarthria, who has a severe low breath support, in those individuals, Alternative augmentative communication can be used. It can be a low tech or a high tech, where alphabet board can be there, or the regular phrases board can be there. Even eye gaze frames these days are available in India, where individual just has to eye gaze the letters and the instrument will speak for you. And the high-tech techniques, high-tech instruments also can be used. Use of tablets. There are many softwares are also available. The well-known software is a Avaz software, which results into the text to speech. And eye gaze technology also can be used. Coming on to the dysphagia management. The dysphagia